Yes, okay. Another study which actually included around about 446 actually teenagers exactly between age of 13 to 17 years. They found out this was a school-based study, just a prevalence study. So they found out like one fourth of these kids, they reported some form of back pain, especially related to sports. So those who were doing sports, they actually complained of back pain some point in time. It was not like that pain and back pain which required, a visit to the hospital, but the back pain per se was present. Again, if we look at male to female ratios in these different type of studies, that it's like almost 1 to 1. So it's not like either males are like more predisposed or females are more predisposed. Can also depend like which types of sports is more common in boys, which types of sports is more common in females. But they found out 50% of tennis and football players, 85% of male gymnasts, they were prone to develop some form of back pain. And all those types of sports which requires like extension of the leg, a lot of your posterior extension of the leg, and this is usually ballet dancing, ice rink dancing, and gymnastics that actually provokes back pain. They are more prone to develop back pain where there are extensive backward extension of the leg. Somehow I think it pulls a lot of causes shearing forces on the ligaments and the muscles of the lower spine. So this was a little bit of the background. Now, as far as the etiology is concerned, we can group them in different, groups. Like some causes can be infected, some can be inflammatory, some can be related to mechanical forces. Then there could be bone-related problem, orthopedics, related to trauma themselves. I told you though, trauma will not be going into the details of trauma. That's altogether a different. So some of the systemic diseases can involve the lower spine, and then there are other miscellaneous non what you call back problems which can actually cause rapid pain in the back. So just briefly going through the etiology, infection can rarely happen in the spine, lower spine, that is the lumbar vertebrae, and it can happen in the bone, it can happen in the disc as well. So, and it can happen in the joints as well. So joints is a bit rare, like sacroiliac infections, more of inflammatory conditions rather than infection. So sacroiliac joint infections in theory can occur, but practically almost like non-existing. Vertebral osteomyelitis is relatively more, again uncommon, but relatively more common if we compare it with sacroiliac joint infection. So vertebral osteomyelitis in this country is mostly secondary to blood-borne infections. Why it happens, why there is more predisposition, we don't know. It might be some form of complement factor deficiencies which make them more prone to a particular type of bacterial infection, or like sort of a reduced or impaired immunity that can lead to that. Because normally if you see spine is a very protected, and normally you don't get sort of a open trauma to these things where bacteria can seep from outside into these particular spaces. Discitis is basically an infection of the intervertebral disc. uh, Obviously these types of children, they have got fever, they can't move, they are just they want to lie still, and very tender condition, uh, grave condition. I mean, if you don't treat, the infection can go into the spinal cord, it can cause paralysis as well. Again, rare. Some of the infections in the surrounding areas can present with pain in the lower lumbar, usually unilateral, and that is, for example, pyelonephritis, relatively more common. It's for upper UTI. Pott's disease, it's tuberculosis of the spine. Spinal epidural abscess can be secondary. Again, why would you get abscess in the spine? It's usually discitis leading to pus formation and eventually like sort of tracks down into the epidural space, causing an epidural abscess. Psoas abscess, again, rare, usually secondary to frank pyelonephritis or some, sort of a retro abdominal infection. But as a general rule, infections are quite rare as far as, our experiences are concerned. Inflammatory conditions are again, it was a relatively more common as compared to, not more common, relatively common to these infections. So one particular infection you all know which has got a predisposition to involve the lower spine and then eventually tracks up to the upper spine as well is ankylosing spondylitis. more common in males. Almost 90% cases are associated with HLA-B27 status. And you might have seen pictures, with of the bamboo spine and, very limited mobility, but that's usually a late stage. Usually, these kids who are mostly adolescent males start with the lower back pain, sacroiliac joint inflammation, and then usually they've got uveitis, scleritis, and eye inflammation. And over a period of time, it takes a couple of years before they have got this fusion of the spinous processes, and that would lead to a bamboo spine. But ankylosing spondylitis is one, again, I would say, relatively rare condition associated with HLA-B27, more common in males. Reiter syndrome or reactive arthritis, though reactive arthritis is more common in knees and hip joints, rarely can happen in the sacroiliac joints as well. Inflammatory bowel disease, especially Crohn's disease, can be associated with extra intestinal manifestation, joint pains, and they can have low backache as well. Whether that low backache is because of referred pain from the inflamed, intestine, large intestine, or whether it is secondary to sort of, joint involvement is debated. Some of the conditions which we call as spondyloarthropathies, like which is usually inflammation of the ligaments and tendons surrounding the lumbar spine. These are usually associated with, if you look at the types of GIA, juvenile idiopathic arthritis, there's 6 or 7 types. So, polyarticular or oligoarticular, polyarticular, systemic onset GIA, psoriatic. There is one like which we know called enthesitis, like in which there is more inflammation of the ligaments. There are what you call rheumatoid factor negative mostly. So they are usually seronegative spondyloarthropathies, and they have got a predisposition to cause low backache. So it's mostly tendons that are inflamed. So Achilles tendon can be inflamed, patellar tendons can be inflamed. Similarly, low, the ligaments which are attaching the sacral, the part of the sacrum to the hip bones, they can get inflamed because there are inflammatory cells infiltrated into those ligaments, and that can cause chronic low back pain. So that is known as, like, seronegative spondyloarthropathies. Then you can have mechanic. By and large, the most common cause of low back ache in children is mechanical. So there is some musculoskeletal cause for it. Most of the time, what would happen, either somebody who has been running a lot develops low backache, or somebody says, I was sleeping, all of a sudden tried to pick something, okay, and then from there, like, started having backache, and that back pain is sometimes present, sometimes not present, sometimes it's present in the morning, sometimes present in the morning. Like, they can have a variety of sort, you gonna, or you can say they can have a varied history. Kids, they don't get herniated discs. They mostly occurs in adults because herniated discs are more common in degenerated. So that is more common in 40 plus age. uh, so in kids who give a history of, like, they were lifting something and all of a sudden they started back against back, it's morely of a lumbar muscle spasm rather than herniated disc, because the discs are like quite sort of spongy, and have got a lot of elasticity in them in children. So rarely they would get herniated, though can happen as well, but quite rare. Then there are some orthopedic lesions in which there you could have, like, sort of problems in the shape of the vertebrae, that the way the vertebrae are, sort of joined on one another. Schumann disease or Schumann kyphosis is one thing, though it causes more of a hunchback sort of a posture, and has got, rather than low, it can cause low back pain as well, but primarily it affects the upper spine, so it affects the thoracic spine. But again, because, see, the whole one thing, the upper, even if the upper part is like, has got a lot of curvature, it would put a lot of pressure on the lower spine, abnormal pressures, and then it also starts hurting. And compression fracture, again, this usually happens in kids who, let's say, who are running away for one reason or the other, and they usually jumped from a high place. So mostly would happen in some form of a renegade teenager who was running away from police, and maybe at train station or somewhere he tried to jump a wall, landed, and after that he started having back pain. So you can think of with that history, there might be a vertebral compression fracture. But again, as I told you, these fractures and things uh, more common in older people rather than in young adults. Malignancies, tumors, osteoid osteomas, osteosarcoma, Ewing soft tissue sarcoma, neuroblastoma, leukemia can have infiltration into the. So there are different types of neoplasms that can infiltrate into the lower spine and can cause low backache. But usually they will have a history of something. So there will be history of a weight loss and some ongoing issues before you get metastasis, or even as I said, primaries are quite rare in the lumbar spine. It's usually the secondaries that can come from different areas and get deposited, and that can cause back pain. Some of the systemic diseases which mobilize the calcium from the bones, like secondary hyperparathyroidism, like for any reason, if your calcium is low, let's say even in renal failure or renal disease, and your parathyroid glands become active, so they secrete a lot of parathormone, and that would to remove calcium from the bones. Bones become weak, start hurting. Sickle cell anemia, though mostly notorious for causing abdominal pain and chest pain, can also cause back pain. And then all the somebody who's using steroids are known to cause weak bones, so that can cause that. And some of the other like illnesses, fibromyalgia, in which there are various tender spots, reflex sympathetic dystrophy, which is I think also known as chronic regional pain syndrome, psychiatric disorders, conversion, pain amplification, and all these kids who have got mental health issues, they can also complain of back pain. So these are some of the groups, uh, of different reasons that can cause low backache. So as you see, there are so many pathologies that can cause low back pain. But the good thing is that a good history and examination can give you an idea like which group might be responsible for causing the low backache. So, how do we evaluate? $1 million question. Most important thing, like I would say, 80 to 90% cases can be diagnosed with a good history and a good physical examination. So, good, I mean, when we say physical examination, the physical examination doesn't mean okay, we do, well, you obviously you would be examining maybe cardiovascular system and respiratory system and neurological system and things like that. But back pain itself, you know, re- requires a good knowledge of the different type of tests that you can do on the lower spine in order to find out that whether there could be inflammatory conditions responsible for that, or whether the sacroiliac joint is involved, or whether the ligaments could be involved. So there are like different types of tests. I will go through some of them, but the most important is to see the movement of the movements at the lower lumbar spine. So spine movements, at the lower, what you call lumbar, where the L1 to L5 and then L5 to S1. So your movements over there are mostly flexion, extension, bending toward the side, and rotatory movements. So these have to be done, and you need to know how much is the degree of limitation and which one brings about more pain. So a history and a physical examination, as I told you, would probably give you a clue in 80 to 90% of the cases. You also need to examine, palpate the spine to see if there are any point tenderness, because point tenderness usually means that there is a focal pathology at a particular point. For example, if one spinous process is tender, there might be a microfracture over there. If there is like tenderness over one transverse process, there might be what you call fracture spondylolysis at that particular point. If there is point tenderness on the sacroiliac joint, which is a large joint, okay, and you're pressing it, it hurts, it might be a sacroiliac dysfunction or sacroiliitis. So you look for any point tenderness as well. But if it is generalized diffuse pain, then you can think it might be a systemic cause or something else. One. Few of the tests which rather they don't help you in but they do help in sort of excluding other conditions which might be responsible for causing some form of back pain. Like for example, if you do a complete blood count and look at the high white blood cell count, or maybe the inflammatory markers are raised, then you know that you are probably dealing with an inflammatory condition. So many. ESR is raised. ESR can be very highly raised in, for example, in tuber. Like you can. There are a few conditions which will be having ESR in 3 digits: tuberculosis, multiple myeloma, paraproteinemias, things like that. And that you'll be probably having ESR more than 100. But ESR is raised. That is another pointer towards like inflammatory conditions. Urinalysis, just to see that there is no sort of a UTI responsible for a referred back pain. Lyme disease can cause arthritis, though that would be more of the knee joint, other joints are, but still, like, it can be done. And those, if they are males, and sacroiliac, so HLA-B27, it's a very sensitive test for diagnosing ankylosing spondylitis. But normally what we would start with, this probably would come, at a later stage, we basically start with this thing. So plain film, so plain X-ray of the I would say lumbosacral spine, not thoracolumbar, like lumbosacral spine, including oblique views. And why oblique views are important? This is important. Normally, we request an AP and a lateral view. Oblique view is very important because spondylolysis basically is more easily diagnosed on an oblique view. You can sometimes diagnose it on a sort of a lateral view as well. But lateral view usually are not very good for diagnosing these stress fractures. So if there is a point tenderness and that child is a young child, gymnast, sort of takes part in dancing competitions, then it's better that you request an oblique view, because oblique view gives you a very particular type of sign. We call it the Scotty dog sign. I will come to that in a moment when I show you the x-rays. So x-rays again uh, help you, because many of these conditions can be picked up on x-rays, especially the fracture, especially if you ask for oblique, and some of the condition like spondylolisthesis or thing. Though there is a tendency these days to go for other types of tests like CT and MRI if you see something on the x-ray, and especially if there are neurological signs, because any back pain with neurology is a sinister back pain. So if any child who's got back pain and has got some form of neurology, that definitely needs an MRI. Definitely needs an MRI if you want to exclude that there is no problem with the cord. And if you are focusing on the bones, you can do a CT as well. But I think MRI is good enough. Like if you do MRI, that covers bone as well as the spinal cord and it's like surrounding tissues. And sometimes a bone scan can also be available, like PET scans can be done for bones to see if there are like hotspots, especially if you suspect that there could be vertebral osteomyelitis. Some of the warning signs in any back pain, if it is an gradually increasing pain, that is a warning sign that something is, it's more of an emergent condition, more of a progressive condition. If it awakes child from sleep again, that is a warning sign. If it leads to sort of decreased quality of life, functional loss, so that the child is now bedridden, is can't even move with crutches, or you know either needs a sort of a walking stick. If there is a history of weight loss, history of fever, neurology, especially bowel or bladder dysfunction, so it's got incontinence or constipation, or has got any form of referred pain below the knees, are gonna, that is also a warning sign. And somebody who's less than 4 years of age, that is also got, these kids, they do not suffer from back pain. And if they are having back pain, then one should be thinking of that there could be some good reason for these things. So to cut it short, history, physical examination, looking for point tenderness, doing all the range of movements at the lumbosacral spine, asking for x-rays, AP, lateral and oblique, and obviously ruling out the warning signs. At least this is the mandate that we can cover in an ED setting. Maybe we cannot request CT or MRIs, but at least we can do this thing and can give us an initial idea what we are dealing with. Okay, so now going with some of the causes of back pain. So if you do an AP X-ray of the lumbosacral spine. Now, AP X-ray is not very good in picking up fractures. Remember, if you're looking at the AP film, it's not very good because you would rarely see fractures. Rather, it would give you more artifacts. If something looks like a fracture, it's more probably, chances are more that it's probably an artifact rather than an exit, because it's very poor, uh, I would say, sensitivity as well as specificity for picking up fractures. Good thing is that it's good at, it can give you an idea of if there is any scoliosis or not. So if you look at, if there is a sort of a angulation of the spine to the one side, we call it scoliosis. So if it is more like, bent towards the left side, we call it levorscoliosis. If it is more bent towards the right side, we call it dextroscoliosis. And then usually what the orthopedic surgeons they do, they try to find out the angle of this curvature. They call it the Cobb's angle. So if you draw a line like this, from, for example, the spine is straight here, from this segment it starts like bending. So I will take this one, so I will draw a line tangentially from here, and then where it comes back, maybe this is the segment, I draw a line from here. So where these two lines they meet like this angle over here, that is known as the Cobb's angle. And the orthopedics, the more this sort of a Cobb angle is, it simply mean more is the degree of curvature. I don't know, orthopedics doctors might know it better. There is a special sort of a threshold, in terms of degrees after which they have to do a surgical correction. So scoliosis is, especially mild scoliosis, in which the body from outside is normal, but if you do an X-ray you will see a very mild curvature to one side. That is one of the most common causes of low back pain in children, non-specific back pain, because the spine is slightly rotated to one side. So because your body, it needs to be straight for order, in order for your body weight to be, your body weight goes like this, and then from here in the spine it is transmitted to both the hip bones, and then from there it is transmitted down to your feet. So if it is like this, then what would happen is the weight would be transmitted more on one side, and it's not like uniform distribution, so there would be pain on one side. So remember, if there is a sort of a low back pain, especially on one side, it's important to do an AP view to see if there is any form of mild scoliosis. Because the scoliosis, then these kids either they need to go on a special brace if it is mild, or refer to the orthopedics. Again, most of the cases are treated conservatively by exercises, posture, and maybe braces. But if it is severe, then it needs to be treated surgically with fixation, pinning, and plating and pinning. Uh, Discitis, I told you, is a condition in which there is infection of the intervertebral disc, and usually you will see that in this case, if you, let's say, if you look at this X-ray, not a very good quality X-ray, but if you look at the spine, you can see that the intervertebral disc spaces are mostly uniform, though in the lower vertebrae, lumbar vertebrae from L1 to L5, as you go down, especially on the lateral view, you will see that the space increases. So like between L1 and L2, L2 and L3, L3 and L4, as you go down, these spaces would increase. But if there is space starts decreasing, that is a very good evidence that there is usually infection over there. So for example, if you look at this X-ray, so look at this, like, this is T12. So between T12 and L1, you can see there is some space. Again, between this is uh, L1 and L2, okay, you can see that there is some space. But between then L2 and L3, you see this is narrowed. Look at this space again, that it is wide here, it is wide here, it is wide here, it is wide here. But this space is unlike the other ones. So this is quite narrowed. Why this is narrowed? Because basically this disk space has been dissolved, like, it's more liquefied, so it has led the upper top vertebra to compress down on the lower one. Why? Because why the disc would become liquefied? Simply because there's infection in there. On the lateral view you can also see the same thing. See here, uniform intervertebral, and then here there is a narrowed one, and then again it starts increasing. So this here, over here, so this is between L3 and L4, you can see that the disc space is quite narrow. So this usually happens in discitis, a rare condition, but a grave condition in which there is, why we call it grave, it's not going to kill per se, but this infection can come here, and here is the spinal cord. The whole spinal cord would be infected, or epidural spinal abscess, and then what would happen? That would lead to paralysis, and obviously that can have consequences. So usually if you see this type of thing on the x-ray, the all of these cases, they still need an MRI, because MRI would give you a very clear view of the intervertebral disc. The other thing is osteomyelitis, vertebral osteomyelitis. Very rarely kids who have got sickle cell anemia might have, because they might be prone to salmonella osteomyelitis. But as I said, like, usually osteomyelitis, even if it happens, mostly happens in the long bones rather than the vertebrae. So rare. So I will not waste time on osteomyelitis. Remember, there's a few terms used which are confusing because they sound very similar to one another. Spondylolysis, spondylolisthesis, spondylitis, and spondylosis. So some of them are like, my tongue stucks, when I try to pronounce these. Spondylolysis. I told you spondylolysis is actually the fracture of the pars interarticularis. So this is an oblique diagram of the spine. So this is one of the transverse process. The superior articular process of the lower vertebra joins inferior articular process of the top vertebra to form a facet joint. So this is known as a pars interarticularis. And twisting forces, when you're twisting and turning, so all the forces transmitted here, so it can get a sort of a hairline fracture. It's not like it will be fractured and in two pieces, but a sort of a hairline fracture can run through. And so fractures of the pars interarticular, which is by and large the most common vertebral fracture in children, that is known as spondylolysis. And again, most of these, this is the most common fracture, number one, from exam point of most common vertebral fracture in children. Number two, the most common cause is non-traumatic shearing forces, like repeat gymnastics and dancing. It doesn't happen because of a direct trauma. Direct trauma would cause like the other type of vertebral body fractures or spinous process fractures rather than the fracture of the pars interarticularis. Okay, then coming to spondylolisthesis. Spondylolisthesis is when one vertebra slips anteriorly on top of the other vertebra. So, vertebral columns are just like a stack of bricks or blocks on one another. So, if the top column slips forward, so if it slips forward, here you can see it has slipped forward. Let's say this is the L5, it has slipped forward on the sacrum. So this is spondylolisthesis. So what would happen when this goes forward? Your spinal canal here, that becomes constricted, because when this part goes in front, what would happen? It will stretch the spinal cord along with it, and the part where it is slipping, that would become constricted. So either that, from that point, it might be affected on one side, it might be affected on both sides. So these children or adults or these patients, like, let me use the word patients, so they would be having shooting pains, radicular pain, like down either one side or the other. So it's just like a sciatica sort of a thing. Your pain is shooting down either on one side, if it's more like affecting the one side, or if it is a general, it might affect the whole cord, and you might be having pain shooting down both sides. So spondylolisthesis is when the spinal cord, the topmost vertebra slips anteriorly on the bottom one. That is spondylolisthesis. Spondylitis is basically when there is a sort of a what you call inflammatory conditions at the edges of the vertebrae. So if you see, this is the inferior sort of a surface of one vertebra, and this is the superior surface of one vertebra. So there are inflammatory changes. Okay, that's why it is itis, because there is inflammation. So this usually occurs in when you have got sort of like I told you, ankylosing spondylitis. That term uses spondylitis. So what is basically happening is that the articular surface is here, and even in the spinous process, they are actually attacked. There are a lot of inflammatory cells here, like especially the lymphocytes. and other types of, inflammatory cells, they just like penetrate this area, they are destroying the bone. So there's a lot of inflammation, and that leads to pain in the spine. So that is spondylitis. It's an inflammatory condition and can occur in a variety of inflammatory disease disorders. Spondylosis is a term which is used for older people. So spondylosis is basically degeneration. There is no inflammation, there is just degeneration. So spondylitis and spondylosis are more or less the same. The areas, they are basically rough, but here the reason is inflammation, here the reason is degeneration. So, when the degeneration occurs, old age. So just like there is osteoarthritis of the knee or of the hip because there is loss of cartilage, similarly, loss of bony surfaces because of age-related degenerative change, not inflammation, age-related degeneration, that is known as spondylosis. So remember, these are four different terms which means different things. In kids, we would either be seeing spondylolysis, spondylolisthesis, or spondylitis. This is for adults, okay, not for children. So coming now to this condition, spondylolysis or spondylolisthesis. So here is a picture of it. This is adults, but if you see, this is in a form of an extreme ballet dancing, okay, which I call it a form of like gymnastics because you have to do extreme stretching, and this involves a lot of shearing forces on the back. Look here, a lot of, you know hyperextension. Here also you can see hyperextension, backward movement of the leg, shearing forces. So normally, I mean, these people have got good strong muscles, their diet is good, but repetitively same thing occurring again and again can cause a fracture in the pars and interarticularis. Now here you can see an arrow, but this is not a very good view. If you ask a very, let's say, a person, an ED registrar who is not that much, sort of familiar with back pains and things, so probably he would not pick up this fracture. Why? Because this is a lateral view. So lateral view is not very good for picking up spondylolysis. We need oblique views, because oblique view gives a very specific type of sign over here. We call it the Scotty dog sign. You can't appreciate a dog over here. Only you can see there's a little bit of like cortical irregularity. Even that is very fuzzy because you can still see a little bit of bridging. So it might be a sort of a chronic fracture with some form of healing as well. It doesn't look like an acute thing. So spondylolysis, basically, I told you, is the defect of the pars interarticularis. It can happen at any point in the lower uh, spine, but usually more common either occurs at L4 and L5. So L4 and L5 are very notorious for this thing happening. So you usually get this Scotty dog appearance on plain oblique film. So these kids usually have got a complaint of low back pain, and if you palpate, that L5 or L4, you will see that they would say they would be having focal tenderness over uh, L4 and L5. You do an AP view, you won't find anything. You do a lateral view, you may or may not pick up the fracture. You need an oblique view. I will show you in a moment. Look at this one. This over here, this BX, this is a lateral view, a true lateral view. The one on this side, the A, this is the oblique view. Why it is oblique view? If you see, the other side is, you can see the pars interarticularis of the other side transverse passes through the body of the vertebra. Here you cannot see through the body of the vertebra. So you have to see, if somebody asks you whether this film is an lateral view or it's an oblique view, because apparently they look like the same. The thing is that you have to look through the body of the vertebrae. If you can see the other transverse process, side process through the vertebral body, then it means it's an oblique view. But if you can't see it, then it means it's a lateral view. So look here, can you see the other side transverse process? No, you can't see. So if you can't see, that simply means it is an lateral view. So here it is. But look here, one is showing through the and the other is showing here. So it is because it's oblique. So one But you can see both of them. One is here and one is here. And that gives a very particular type of an appearance on the X-ray. Can you see it looks like a dog? See, this is the ears of the dog. This is the mouth. This is the front legs. This is the hind legs. And then this is the tail. So they call it the Scotty dogs. The Scottish dogs, they have got this type of, they've got big mouth and fur hanging from their mouths. That sort of dog you might have seen. People are very fond of keeping. So you might see this type of dog with people. So that is known as a Scotty dog. So this Scotty dog sign you can see here. Look at this one. Now this is an oblique. Now if I just like hide this one, and if there were no arrows, and if you look at that, you might say, well, doesn't look like an abnormal film. Doesn't look like there's a concrete fracture, because normally what we do in ED on a lateral film, we look at the anterior spinal line. So we draw a line which actually is looking at all this anterior part of the vertebrae. Well, that is in a line. The curve is in line. We look at the posterior one, that also looks in a line. Okay. Then we look at these vertebral arches, they also seem fine, and we draw a line through the end of the spinous process, that also seems in a line. Well, all the four lines are parallel to one another. Doesn't look like a, but if you see here, this is unlike over here, though this is a lateral view. I mean, some of them, a sharp person would pick up, oh, this is from possibly a chronic fracture over here, a stress fracture. Why it's a stress fracture? Because it's not acute. There is fracture as well as there is healing. It's not completely broken. It's not completely healed as well. So you can see a bridging of, this callus formation as well. So that is, excuse me, having a. So here also, if you magnify this one, you probably see a little bit of radiolucency going through this one. But you can't, actually, it's very difficult to pick it up. This one, somebody might say, oh, well, looks like a fracture. But if you have got an oblique view, then look, if you look at the Scotty dog here, okay, look, there is a break here between his head. This is the neck and this is the front legs. So there is a fracture here. And if you look at this one as well closely, the neck seems fine, but there is a very faint line where this red dot is laser pointer. If you see, there is a very faint line going through that. So there is another fracture here as well. So it's got an pars interarticularis fracture at L4 and at L5 as well. So there are two fractures. It's very difficult to pick it up on the lateral view, but relatively easy to pick it up on oblique view. That's why if somebody has got backache, we should, normally when you do a request through the DART OCM, they would only do two views. So, I mean, rarely because I told you these cases are rare. So if you are making a DART OCM, then it's better call 6867 X-ray, what you call, South thing, and tell them that I'm sending a patient who I think might have a fracture of the pars interarticularis. So please do an oblique view as well. Include an oblique view. So that oblique view would give you a clear idea whether there is any fracture of the pars interarticularis or not. So that is known as the Scotty dog sign. So if the neck of the Scotty dog has got a sort of a radiolucency, that is fracture of the pars interarticularis. Then the other one is spondylolisthesis, which I told you is slippage of the vertebral column on top of the lower vertebrae. So there are two X's there. I ask you, which one shows spondylolisthesis in this one? Question to you guys. You tell me. Come on, guys. Why there's deafening silence? Come on, tell me which one has got spondylolisthesis. I just gave you the definition. You tell me which X-ray has got A or B has got spondylolisthesis. Looks okay. Both of them are okay. I'm just asking you to pick one pathology. There might be multiple pathology, but just pick one thing. Is which of these X-ray has got spondylolisthesis, or you think both are abnormal, or you think both are normal? Yes. Hmm. Okay. Okay. Fine. Fair enough. Anyone else? Yes. Who else is here? I mean, I can't see at the moment because I'm in front of my presentation, so I can't see the team's sort of participant list. So whosoever is there, uh, can you just quickly tell me which one has got spondylolisthesis? Just tell her to write it in the chat box, Vishika. Okay, B. Okay, who else is here? Okay, what do you see in A? Okay, let me tell. So it is basically it's the X-ray B which has got spondylolisthesis. Okay, why? I will tell you. If you just draw the line, okay. So if lateral, if you draw a line like this, okay. I told you it's the slipping of the vertebrae anteriorly on the top of the other one. So here, this is the vertebral column. I'm not going to draw the third or the fourth line. Can you see the lines being drawn on your screen or not? Can you see or not? You can see the line. Okay, fine. Now I will draw the same lines here. The anterior vertebral line. And this I'm drawing the posterior. And when it comes here, what did you see? So can you see that in B, see this is if you draw a line, it's easy if you draw a line, after there's a step in the line, it means that this thing has slipped anteriorly. So see L5, the whole column from top, L4, L3, L4, L5 has slipped anteriorly on the sacrum. This has slipped anteriorly on the sacrum. So this is spondylolisthesis. Would it give any form of uh, neurological like symptomatology? Fine. So it will not be compressing of the cord because actually there is no cord here. Cord actually finishes, conus medullaris, so it's the cord finishes at L3 and L4. So you've got a plexus coming up here. So the thing is that it would not press on the cord, but it can press. There is a plexus of nerves going in here. So you can have like sciatica like symptoms, radiculopathy, rather than compression of the spinal cord, because if there's compression, we are talking of like what's that called, what's the name given to that, which is considered to be an emergency. Oh God, cauda equina. Correct, point, like more on the, so this is here because the conus medullaris just finishes here, so it's more of a nerves coming in, right? So the lower the spondylolisthesis, has got more tendency to cause radiculopathy. The more superior it is, yes, it can cause like severe compression, and that can be more of a sort of a widespread neurology in this particular area. So this was spondylolisthesis, in which lateral X-ray can actually tell you. You just draw the lines, and if there is a step in that, you can tell that it's spondylolisthesis. Then in AP view, another one thing is what we call as the winking owl sign. Winking owl sign. So if you look at the AP view, you see the facets, okay, of the transverse processes like eyes of an owl. So if you see, this is the spinous process. This is the spinous process. Another spinous process of the top vertebra, and these are the pedicles of the transverse processes which go sidewise. So it looks like an owl. This is the nose of the, if you look at this side, and eye. So this is known as the owl. So if you see, it should be present on both sides. But if it is not present, see here, one side is present, the other side, there is no this sort of a thing. Okay, I will just draw like this. So there is nothing like this. So it's a missing, or we call it a winking owl sign. So if a winking owl sign is there, remember in children, if you see a winking owl sign on an AP view, that means a secondary deposit, a secondary malignancy, unless and until proven otherwise. Look at this one. So this is the T12. So you can see the pedicles, okay. Here in L2, you can see, okay, L3, you can more or less see one is slightly not that visible, but here if you see, you can see one on this side, but there is nothing, no this sort of a, so there is a winking owl sign on this side. It means there is a secondary deposit in this L1 vertebra. It could be coming from anywhere, but it simply means that there is a secondary deposit, metastasis from somewhere. And children could be leukemias. Okay. Then one of the most, no, I would say common causes of pain in children is Bertolotti syndrome. So Bertolotti syndrome is basically, it's not a, I don't know whether to call it pathology or not. It's a variation of the normal. But this variation of the normal has got a tendency to cause back pain. So what happens in this particular case, there is a CT scan reconstruction. It is a problem of the L5, because L5 is the vertebra where it meets the sacrum, and that, if you see, this L5 has got its transverse processes. But what happened, one or both transverse processes can actually develop abnormally. So instead of like being like a wing, you see this is actually a whole flap, like a, what you call, like a ear of an elephant. Here this is a joint, the L5 and S1, and then the S1 is making this joints with the ilium bone. So these are your SI joints, sacroiliac joint here and sacroiliac joint here. But this sacroiliac joint is complicated because now the transverse process of the, I would say the right transverse process of the L5 is making a joint. This is known as a pseudo joint, because this is not a true joint. This is a pseudo joint. I'm writing with mouse, so maybe not very, pseudo joint. They also call it like temporary or transverse joints. Okay, so this is not a proper joint. So, but because it's making a connection with the other bone, so the area where there is a connection of one bone with the other bone is known as a joint. So this is a pseudo joint. But what happens, because this is not a proper joint, there is no cushioning, this leads to irritation between the two bones and is a cause of pain, chronic back pain. They say around 10 to 20% of the population has got this thing. 10 to 20% of the population has got this Bertolotti syndrome. Another thing is it doesn't cause pain in all the people, because as long as they are not making too much movements, it would not lead to irritation and they would not. But let's say in children, because they are very active, there's a lot of movement over here that leads to irritation. And what happens is that this then leads to pain. So unilateral or sometimes bilateral lower back pain, okay, when everything is fine, including straight leg raise test and no neurology and nothing, and it's off and on, mostly with sports, you have done x-rays, you couldn't find any spondylolysis, there is no spondylolisthesis and things, think of Bertolotti syndrome. Like, look at this x-ray. This is a normal x-ray, nothing wrong. You can see the owl eyes, okay, nothing, no winking owl sign, all the disc spaces are absolutely normal, okay. But and this also looks normal, you can see the second thing. But here, if you see, this is the transverse process of the L5. Here it's like this, okay, and it's making connection here and here. So it is something like this, like the ear of an elephant. So there is a Bertolotti syndrome over here. So Bertolotti syndrome, and why I wanted to mention this thing, I think none of us working in CHED knows about this syndrome. This is one of the most common causes of low back pain. And the good thing is it is usually treated conservatively. Uh, Normally, if it is causing too much problem, then the best thing is to give a sort of a non-guided injection into this area. See, if there is an, let's say, if there's a lot of inflammation in the sacroiliac joints or things, some orthopedic doctors, they give guided, like under fluoroscopy or under ultrasound guidance, they can give injections into this big joint from the backside. But in ED, one thing that can be done is an unguided. Unguided means you don't need an ultrasound, you don't need a sort of a fluoroscopic thing. You just put, so if the person sits on the back side, like if the person is, let's say, sitting like this, okay, on the back side, this is the chair. So there are two dimples on each side of the lower back, okay. These are just over the posterior superior iliac spine. There are two dimples over here, okay. So this is the dimple where you have got this area. So you just infiltrate a little bit of local anesthesia in this area, and you just take 23G needle, and you just go blindly till you hit the bone. And you normally take, I think, 2.5 mils of what's this called, methylprednisolone, silomedrol, uh, and zero point 0.5 mils of bupivacaine, and that's usually injected in different areas. So that leads to like immediate sort of a pain improvement, and helps like at least for 6 to 7 months. But again, depends, nobody does it these days, but like, in independent practices, this can be done if somebody is like totally, sort of incapacitated by the pain, because it usually leads to mild pain, but sometimes it can lead to severe pain on the affected side. So unilateral or bilateral low sacral pain in absence of spondylolisthesis, in absence of spondylolysis, in absence of any neurological signs, think of Bertolotti syndrome. Okay. Then we have got the Schumann's kyphosis, which is basically a hunchback of the thoracic vertebra. So if somebody leans forward, you'll see it is more of a like a dome appearance of the uh, upper thoracic spine. You can say it's more like sort of a kyphosis, exaggerated kyphosis of the but it can also cause load, because when they are like this, so they're putting a lot of pressure on these muscles to pull them up. So they can have bilateral lower what you call back pain. Then so you can see here, see how much like sort of a hunchback appearance. Then moving on to enthesitis and ankylosing spondylitis. Enthesitis would be, some kids have got tenderness over the sacroiliac joints, like you put your thumbs in and they are like, they are in terrible pain. That can be because of enthesitis, because there are ligaments on this both sides of the sacroiliac joint. We call them the sacroiliac and the sacroischial ligaments. and these ligaments can get inflamed in what we call, enthesitis, or we also call them seronegative spondyloarthropathies. And other tendons can also be involved, like the patellar tendon, the Achilles tendon, the what do you call this, the tendon over here at the elbow. So they can be involved. So if there is a sort of a history of pain in the other tendons as well, and they've got low backache, think of enthesitis. So again, that can also be treated with localized steroid injections. Juvenile ankylosing spondylitis, as I told you, it's more common in males. They will be having HLA-B27 positive status. They can have eye findings. They can have like urethritis, low-grade fever, things like that. This is how we differentiate between the juvenile idiopathic or rheumatoid arthritis and juvenile ankylosing spondylitis. So see, in juvenile idiopathic arthritis, females are more commonly affected as compared to male, while in ankylosing spondylitis, 7 to 1, 1 to 4, like one male, four females, there are seven males and one female. This usually occurs at a younger age. This usually occurs in adolescence. Back pain is very rare in JIA. It is almost 100% a common feature of ankylosing spondylitis. Enthesitis is rare. It's very common in ankylosing spondylitis. 90% would be having HB27 positive. Only less than 5% are ANA positive. Less than 5% are rheumatoid factor positive, and iritis is usually acute. So they will be having red eyes, inflamed eyes, painful eyes, can lead to visual loss as well if not treated with topical steroids. And then, last but not the least, some girls might have what we call as pain amplification syndrome. So they have got chronic backache where everything else have been excluded. These are the one who usually have undergone CT scan. These are the one who usually have got MRI. Okay, the MRI have been done. They are the ones who have been taking painkillers, every type of painkillers, including like what you call morphine, and still their pain is not subsiding. And pain, they say, is out of proportion to what fine. The physical examination is absolutely fine, absolutely fine. So it can be associated with chronic regional pain syndrome. The chronic regional pain syndrome mostly occurs in limbs rather than at the back. Causalgy or pseudex atrophy. Okay, well, that can also sometimes, or some girls can have fibromyalgia in which there are multiple tender spots, and that some of the tender spots can be in the lower back as well. Or they can be those who are type A personalities. These girls would be mostly coming from grammar schools, very good in academics, but might have a history of self-harm as well, or mental health issues as well. And usually if you see their carers are the history giver, so it's more than more anxiety of the parents rather than the child himself. you know that, oh, she's got this and that, and we have done this and that, and nobody has been able to pick up a diagnosis, and this and that, and she is not going to school for a few days, she's been incapacitated. And then you are like, scratching your head. MRI is normal, CT is normal, X-rays are normal, she's been on painkillers, what else? That is pain amplification syndrome. So it's just like, pain is there in their head. uh, and some of the extra musculoskeletal causes which can cause back pain: menstruation. Okay, so it's like if they got periods, they can have back pain. Obviously that has nothing to do with the lower spine, I think. Endometriosis can cause, because there is like sort of an endometrium depositing on the ligaments of the pelvis, that can cause periodic severe low back pain. Chronic pelvic pain because of the pelvic floor instability, because they have got a different shape of pelvis, android, or android pelvis rather than the gynecoid pelvis. So that can also cause stretching of the uh, muscle, and the ligaments can give them retroperitoneal pathologies, like for example retroperitoneal fibromas, or fibrosis, things like that. And some kidney pathologies like renal stones, infections, they can give low back pain. So this was a sort of a detailed lecture on the cause of the low back pain. What I would say that the take-home message is that good history taking, good physical examination in which you check the range of the movements of the lumbosacral spine, flexion, extension, lateral rotation, um, things like that, straight leg test, checking and ruling out any neurology, seeing that there's no saddle anesthesia, asking about any history of incontinence, Remember, they might have a little bit of back pain referred to buttocks or thighs. That is not, that you see, that is not abnormal. Only a pain which goes below the level of knees is abnormal. Or if the straight leg, raise test, if that is positive, then you would say it abnormal. Other than that, they can have all these things. They cause spasm of the muscle, so they can have a little bit of spasm of the gluteal muscle advance. So the pain would be radiating to the buttock as well. X-rays, three views: AP, lateral, and oblique. Why oblique? Spondylolysis. Why lateral? Spondylolisthesis. Why AP? Look for if there is any Bertolotti syndrome. And as I said, also think about extra musculoskeletal reasons for low back pain. So this was all about the diagnosis and management of low back pain in children. I'm done with the lecture. If you've got any questions, you feel free to ask me now. Yes, folks, anyone? Any questions? No questions? Well, you see, appendix. Okay, acute appendicitis, number one, only if there is a retrocecal appendix, again, which is rare. Then the other thing is that, there would be a history of abdominal pain, and then, so that there's probably some form of abdominal pathology radiating to the back. I mean, per se, somebody coming with a long-term history of backache on and off, why would you think of appendicitis? Unless until somebody comes with an acute pain. Sorry, I didn't understand. Do you? Oh, orthopedic. Okay, if there is any neurology, any fracture, any neurology. Okay, so if, like, let's say, if it is, let's say, spondylolisthesis, spondylolysis, and any neurology. So you have to call the, though, as I told you, then spondylolisthesis and spondylolysis, they would also, they will just treat them conservatively. They will treat them conservatively. So obviously, in maybe in adults, they can put them in a brace, in a lot of lumbar brace or lumbar corset, but in children they don't place, because it doesn't help, because it leads to more stiffness and things. So it's just like it comes under them. Like, they would simply take the details and they will just follow them up. But other than that, management doesn't change. Management will be the same thing. Okay, so if there are no more questions, thank you very much for attending. And that's it. See you next week then. Okay, thank you very much. Take care. Bye bye. Welcome, welcome. Anyway, take care.